Good afternoon, ladies and gentlemen. It's my privilege to introduce Professor Judit Simon to you today. Professor Simon is Professor of Health Economics and Head of the Department of Health Economics at the Center for Public Health at the Medical University of Vienna. Her background is most interesting because she has held several appointments at UK universities and other scientific institutions. She holds a Doctor of Philosophy in Public Health from the University of Oxford, a Master of Science in Health Economics from the University of York, and several academic degrees, including a Doctor of Medicine from her alma mater, I assume, which is the University of Szeged in Hungary. At the moment, she is, as I said, head of the department, and inter alia also visiting professor of cognitive health economics at the Department of Psychiatry at the University of Oxford, other roles still active in Oxford, and also involved in the Ludwig Boltzmann Institute for Applied Diagnostics, where she is head of health economics. Professor Simon is therefore a most active and practically and academically speaking active person. We have one thing in common, as I just learned before this starting of the conversation today, is that she also came to Vienna some years ago and was asked to build up a completely new department, this department that she is still running, the Department of Health Economics, from scratch. And it will be very interesting, therefore. Thank you, Professor Simon, for coming to share your experiences on this. But let me, before asking you this, just explain why you are invited here mainly today. The main reason why you invited here is that you and your department started to publish on several aspects from a public health and a health economics point of view on the ongoing COVID-19 crisis, in particular, but not exclusively, but in particular on psychiatric and other mental health issues that come with COVID-19. Thank you very much for being with us. First question, therefore, how is it to build up a department in Vienna, and what are you doing as a department at the moment?
Yes, firstly, thank you very much for the invitation. It's a pleasure to be here, and hopefully we will have an interesting 1 hour. And also, I would like to welcome the audience who are sitting somewhere in the background. Coming to Vienna, I was in Oxford before. It happened to be a new country, a new language, a new institute. So these are already, anyone who works in academia knows that these are gigantic changes in life, in work experience. And I think we already touched upon it, that I was very much welcome, and the Medical University had a great support to establish this new line of research, health economics at the university. On the other hand, we know that Austria is not the fastest in administration and bureaucratic issues. And as we already touched upon, we experienced similar issues in the first weeks or even months of starting in Vienna, that despite all the support, having a computer or a printer even proved difficult at the first moment. But these are, I think, hurdles and challenges one happily oversees when you have the task to build up a new team, which I had. And I can say now, after 7 years, that it's a wonderful team of young researchers and administrative personnel we have. We have about 12 faculty members and administrative persons, and a few additional PhD students at the department. We do a lot of work, mainly focusing on economic evaluations. It's an area of health economics trying to support decision-making with evidence. Decision-making in terms of comparing different treatment options, which one is better value, more cost-effective, what should be the order of treatment pathway for different patients, and also trying to discuss resource allocation questions and providing expert information and data for this. So this is the profile of the department. In terms of background, we are very mixed. You asked me to touch upon this as well. So we have people with economics background. I have some PhD students who have clinical backgrounds. They are medical doctors, but we have mathematicians, public health people as well, social scientists, because health economics is in reality a social science. So it's a subspecialty of economics. And so I think we are an independent institute and very much focusing on working with clinicians and decision makers about producing health economic evidence.
Are there any lawyers in your team?
No lawyers. Okay. But we work very closely, which I know you will not, with ethicists. Economics and ethics have a lot of in common, and as part of this collaboration, we very often stumble upon legal questions. So I'm sure these are free approaches to the same questions.
Absolutely. I saw that you were publishing with Alena Büchs, for example, who's a colleague very active in ethics. Actually, from a lawyer's perspective, there are some differences between ethics and law, but I'm very much aware of that for non-lawyers, this is in a way the same field, right? So because it's normative in a way.
I actually, why I mentioned, because we have, there are a lot of, it's fascinating, I think, when you work in these multidisciplinary teams to see that how the same question, how differently you can approach. And we actually had quite a lot of discussions with Alena about the same question before even writing the publications or designing the study and trying to find a common ground. So I'm sure legal people would be the third angle to the same question.
Absolutely. And it's very interesting. This is more a problem of my domain now. It's very interesting to see that the legal people are often rather disconnected, both from the economical and from the ethical debates that are ongoing. And the legal layer is somewhere isolated, coming at the very end and not necessarily linking together everything in the best way possible. And perhaps this is even something which we see in the ongoing COVID-19 situation now, without needing to go into any detail here already now, but if you wish we could, because I think this is also happening at the moment, right? So the legal layer, which is the COVID-19 Maßnahmengesetz and all the other regulations, is set in between the political debate and the expert debate and the communication outside. And I'm wondering why this is. I'm not sure yet why this is, but from a legal point of view, it makes things rather difficult because you are always late and you are always the killjoy in a way, or the troublemaker. Which is part of my day-to-day experience, but it's rather exhausting if you do it in every day, right?
Yeah, it's not proactive activity at the moment, but more retroactive. Yes, and you hear. I'm not an expert, and I find this discussion also very interesting on my side. That what you learn from the media is that usually first something happens, and then you have to adjust the legal background to it, so that at the end it works on all sides.
Yes.
And I think this is exactly what you mentioned.
Absolutely. The typical self-understanding of many lawyers is react to something which has already happened and bring it back into order, and not proactively shaping the future, right? So it's a different domain. Absolutely. But in principle, is it a coincidence that lawyers are not part of your team, or is this true for the whole academic discipline or peer group in which you are in, that lawyers do not really play a role in this?
No, I think what we are doing is collecting data and analyzing it, and this usually requires very strong quantitative skills, and then providing the results as evidence to decision making. And I think what happens then with this evidence then already is moved to the decision making level. And I think this is also where the legal impacts come into. So we kind of provide the information. And then what happens to that information is not dependent on us. And I think this is why we are not directly working with lawyers. But for example, I have to admit that in that sense that we develop new tools, for example, questionnaires. I'm also coordinating a big European project there as well. We have a lot of new tools coming out for economic evaluations. And when we are thinking now about commercialization and developing business plans and how to make this available for the public, there we are involving, of course, people who are experts in IP and also relevant law. And we work with colleagues from the Medical University in this respect. But this is more of a, again, next step.
Yeah, and this is more from a lawyer's point of view, this is more serving you in a way. It's
exactly,
a kind of helping you.
It's not a service rather than creating together the product.
Yeah, whereas the first question is more also about the product, because the policy making and the decision making on the decision level or on the political level obviously is happening in a legal framework, and somebody needs to translate this legal framework to the policy level, because otherwise, if this doesn't happen, and in some ways it did not happen properly in some of the COVID-19 regulations that we saw, if it doesn't happen, then at the end, the Constitutional Court or somebody else appears, or somebody like an academic like me appears saying, this will not fit, it will not work, it's not ready, it's not well developed, and so on. And even at the beginning, when you were doing your empirical work, I would assume that already the questions that you ask are or can be biased in the way that they might have an impact on how to deal with this from a normative level. So also on that stage already, I think it might sometime be useful to speak to lawyers, right?
I actually will take you on that what you just said, that it's very important how you ask the question. And I think this is something what is very important for us academic researchers in health economics, that when I arrived to Austria, I experienced that very often here people ask the question, could you do a study, could you do an analysis and show how much better A is than B? Yeah. And then I always say research does not answer a question, how much better A is than B. Real objective research answers the question, how different is A from B? And maybe that A is better than B. It might be that they are equal, or it might be that A is worse than B. Yeah, and I think this is a paradigm shift. I'm very happy to notice that it's also changing now. That evidence is not anymore required to support some hypothesis and interest, but rather to really answer questions. And I think COVID here tremendously changed the landscape.
Okay. Interesting, because my perception of the evidence as it was introduced into the legal/political debate in this COVID-19 crisis was clearly dominated by assumptions about how the world should look like. So it was the opposite of how alternative A, B, C, or D might develop. It was clear, and it still is very clear in my view, that there are some targets that should be achieved, and then everything needs to be fit to that target, including the statistical evidence, and not the other way. But perhaps it's just, again, my lawyer's perception. Would you not agree on this?
No, I would not agree. I think a lot of the modeling that is going in the background is not supporting, you have to come up with a certain number to support the political decision, but trying to preempt what will happening. But I think it's, again, maybe we are involved in different sections of the decision making, and I can see that this might be why we see this differently. On the other hand, I have to agree with you that, and today I just had a journal club with my students, and we discussed this, that what is really what is the ultimate aim? Yeah, we have to define what we want to achieve. In health economics, the ultimate aim is to develop evidence which helps to create the most health from a given budget, where you have some restrictions, some cost restrictions, and you have to look at which options will give you and produce at population level the most health. Therefore, I not necessarily, from a health economics viewpoint, if you conduct the relevant analysis, not everything that happened in Austria or in any other countries and decisions would fulfill this, this general health maximization object. But as we know, politicians and governments not necessarily just have to listen to evidence, and this is what is happening, and maybe this is what you are referring to, because we live in a society. There are human beings involved, there is a culture, there are different value sets, and I guess governments have to or take all of this into consideration when they are making their decisions.
There's a lot of very interesting in what you're saying. Let me start with the following. Perhaps I should clarify a little bit more what I meant before. So my feeling from the very beginning, from March onwards and until today, is that there is, for example, a clear goal, which is under no circumstances ICUs in this country may be overpopulated. So we need to do whatever it takes to avoid a situation where people do not get an ICU bed if they need one, which is interesting because it's not identical with your assumption that the maximum of health needs to be achieved. And it's also interesting because I mean, there are other implications of this political goal, if it is a political goal, that are not health related, that are also important, such as the economical situation of the whole country, the well-being of the children, I don't know, the situation at the universities, job market, and so on, right?
Yeah. And these also have health consequences. Yeah.
Indeed,
so
absolutely,
yeah,
absolutely.
Exactly.
A lot of this is health related, and I understand that in March, when all this started, everything was difficult because it was very new to everyone. But since March, there would have been plenty of time to debate in an academic environment, and also in a political environment, and also in a legal environment, whether those assumptions are the best ones to take. And in my view, it's not only a political question, it's also a legal question, it's a public health question,
exactly,
it's et cetera, et cetera. And my view on or my perception of the situation in Austria at the moment is not really all these debates are in the public domain at the moment. If they are happening somewhere, I'm not really aware of them. And that's what I meant by this, by this preset of norms or values.
Yeah, I fully agree. I think we in reality, in a normative world, we need a multidisciplinary team discussing and contrasting the different value views and standards in an open debate and trying to come up with the best solution. But what I was trying to say is that while I'm very much an evidence-based person, we have to be, of course, aware that we live in a society, and there are other values necessary as well as evidence. And I had very recently an interesting debate with my husband. We talked about how to prioritize people for vaccination, and is this the right approach or not? Some countries internationally decided to vaccinate younger people. And initially, some would say, why do we vaccinate, the elderly, the very old? I'm talking here about 85, etc. But because they already had affair innings and things. And this is someone maybe superficially thinks. But then I did a quick back on the envelope calculation, looking at what is the average life expectancy at that age of still people who are already 85, etc. And what happens? And it turns out that it is actually right to save these lives, even in terms of value judgment and health. And when you look at modelings, there are very good one in Canada. They also looked at, should we look at the direct benefit of vaccination, reducing severe consequences, where of course then the elderly and those with already pre-existing conditions should receive first the jabs. This is what is happening in Austria as well, in addition to the critical infrastructure workers. Or should the more active, middle-aged, young generation who are actually the big spreaders of the virus get vaccinated, and more focus in this indirect impact, because at some point with this indirect impact, you are maybe saving more lives also among the elderly. And this was simulated, and they came up with an answer that until we have a bigger proportion of the population either immunized or infected and already over the infection, actually the better approach is to start with the direct impact and immunize the elderly and all the other priority groups we are doing in Austria. So I think these are, again, you can discuss this at a more social level, and social values. And you can then also subject this to evidence base. And I myself was very surprised, to find out when I read about this more that this is actually even the objective evidence supports something like this.
Yeah, that's very interesting. Absolutely. Could you then perhaps give me a short impression, or share with me the impression whether you think that this transfer of the evidence-based knowledge into the political system and into the political decision-making in a crisis like this one that we are facing at the moment in Austria is organized in the best possible way, or whether you would see some room for improvement there, and if so, where?
I don't think I'm the best person to discuss this in that sense, that I'm not sure that I see and know all the angles of what's happening in Austria. I can only give a personal opinion. There is definitely room for improvement. But if you look at internationally, I'm also involved in the European Public Health School COVID task force, and there we discussed this. As many countries as different approaches to this. And it's very much influenced, again, by culture, by existing advisory bodies, whether there are these already in place and they can now be retasked to deal with COVID, or they have to be newly set up. Who should be, how the members of this task force need to be selected. Definitely they should be multidisciplinary. I would say that definitely there would be, I think, opportunity to have more transparent expertise brought in. But I would be, I think, the prime minister of this country if I would know the answer to this. And I think, again, it's very easy to criticize and not providing necessary better solutions. I don't think there is a one bill fits every country solution to this.
Okay, then perhaps a little bit more precisely asked in another way, are there any measures taken so far in Austria in where you, from a regulatory point of view, such as lockdown, schools closed, universities not open, etc.?
Yeah.
Any of those measures taken where you have the impression that the evidence base is insufficiently developed, or is everything in a way at least, or did the transfer at least work in the way that everything can find the basis in the evidence if needed?
Yeah. For this, I would need to be involved directly in the relevant committees, etc., to know what evidence is discussed there. Yeah, in order to answer this question. So I cannot answer this question. But I know that, for example, the Corona Ample system, there is a group of different expertise involved discussing whether everyone necessarily sits around the table. I cannot tell you, and I don't know what the discussion is in these committees.
Yeah, and the traffic light system is gone. It's no longer
active. It was a wonderful thing in September, but we don't have any more regional. It's in red since several months now, and it lost its, for example, its meaning. But when it was set up, this was, I think, a great example, trying to establish an expert committee behind it. Yeah. So as an initiative, I think this is a positive impact.
Okay, I see. Okay, perhaps if I may, Professor Simon, we could go a little bit more into detail about some of the research that you undertook personally in the field. So one of the papers that I'm referring to deals explicitly with mental well-being, social connections, and existing vulnerabilities in Austrian population, and you did a survey on this. Perhaps that would be a good starting point, if you agree. And the other one is the paper on in this ASFER newsletter from November 2020 about the overall situation in Austria from a public health point of view, where you contributed quite a lot. That would also be interesting. Please choose which one to start with. The second one is probably the more general one. The first one is the more specific one. So I don't know how you would like to take it, as you prefer. But please give us a short impression about what's going on in this country from your point of view.
Yeah, so maybe I will start with the mental health specific one, as today's discussion, this was the topic, and up until now we touched not, I mean, it was more of an introduction discussion. So this study we conducted in that sense that I do a lot of research in mental health, in general mental health economics. And very early on in the pandemic, it became clear that the pandemic doesn't just have severe consequences in terms of infection and COVID, but it has tremendous mental health impact. And I think if we look at the longer term perspective, then this will continue at least for 10-15% of the people currently impacted way beyond the end of the pandemic, which hopefully we will see at some point. So this was a research topic that was in any way very close to my expertise. Another research, what we do is outcomes research, and to really try to see what are the best outcome measures to really capture the impact of COVID on mental health. And there is the capability approach, which was developed by Amartya Sen, who is a Nobel Prize holder. I don't know whether it says anything to the legal audience. It's basically an approach looking at saying that if you just try to measure outcomes in terms of functioning of a person, you don't get the right picture, because a person who is starving because there is no food to eat versus a person who doesn't eat because of fasting due to religious beliefs, if you observe these two people, both of them are not eating, so at functioning level they are the same. But if you know what is lying behind, what is the freedom of eating, then it's a completely two different scenarios. And this is what capabilities are trying to look at, this freedom aspect. And this is another area where I'm doing quite a lot of research. And we felt that this should be looked at together with the mental health impacts in this study. So what we did, we surveyed using an online survey over 550 people back during the first lockdown, asking about their mental health status, asking them about their social contacts and support, and asking about their well-being and capabilities, and looking at the different characteristics of the people, how these influence the results, and they belonging to some vulnerability groups. By vulnerabilities, we mean for example, people who have long-term physical illness and they are at high risk of severe COVID, or people who had pre-existing mental health problems, and therefore the disruption to healthcare services. And this is another angle, I think, going back to our previous discussion, that why COVID completely dominates everything, the media, the healthcare services. It seems like that somewhere in the background, the routine healthcare services were forgotten. Yeah, and this is impacting tremendously people with existing mental health problems. So we looked at different vulnerabilities groups, and what we found that actually the mental well-being of this sample were 30% of the people had actually a low mental well-being during the first lockdown, and this even got worse during the second lockdown, where we repeated a second wave of the questioning, comparing for a subgroup of people between the first wave and the second wave. And what we also found that while during the first lockdown, it was anxiety which was causing a lot of the mental health issues, This seemed to be improved over time with the COVID pandemic, and it's depression that is then becoming more dominating during the second lockdown and as we continue with the pandemic. And definitely it's looking at all the different vulnerability groups, including critical workers, etc. People with previous mental health treatment seem to be the most impacted. And one of the biggest decisive factors is the social support system around this. So I think yet another emphasis that when you want to improve health, it's not necessarily healthcare interventions that you need to look at and in these public health decisions by governments and measures, but also the social angle and to make sure that people have sufficient social support systems around them.
So I find this number really striking, that 30% of your participants reported low mental well-being already in the first wave. And I would expect, as we are in the third now, and perhaps a fourth or a fifth coming, that the situation is worse now and will probably become worse in the future. And again, I would really be interested in the self-understanding of your discipline. Is in your self-understanding, your discipline ending at this stage? So you are providing the evidence, which is the situation is bad and it's getting worse and worse. And somebody else should translate this into a political measure or a law? Or is it still part of your discipline and your self-understanding to provide at least options that would be available now to deal with the situation, such as, I don't know, help people in their personal environment, increase the number of or increase low-level entries to psychological help, etc. So where does your discipline end, and where does the political debate start?
Mm-hmm. I think the core of my discipline ends by providing the evidence.
Yeah.
It doesn't mean that it ends fully here, but I think to provide options and solutions to the problems, I think, hugely overestimate my skills, saying that I'm in a position to do this alone. Mm-hmm. And this would require joining together with lawyers, joining together with ethicists, joining together with clinicians, joining together with social care and generally care responsible people, joining together with managers, with politicians. And there you are already in a group who should then, based on this evidence, debate this evidence and come up with a solution. I see our discipline necessary to be part of this discussion, but not as the sole provider of the solution. I think this would be a huge overestimation.
Okay, I understand that, and I share that point. I would, however, like to ask you whether you have the feeling that anybody in this whole social system that is very complex in which we are in, that anybody of that realized those figures as being important? I mean, is there any feedback on this?
Yes.
And did you see any measures taken as a reaction on this research that you would like to emphasize?
So in terms of Austria, this research has been published. the ASFER report has been published. I had some recent discussions with the social insurances. And I'm not the only one who is researching this topic. Yeah, there are other colleagues who are looking at suicide, etc. Definitely, it's gaining attention. Whether anything has been done specifically on these results, I'm not aware as the impact. But I can tell you that all of the international evidence that is emerging and where we are part of this, the WHO, the World Health Organization, actually run a survey in 130 countries in last year, over the summer, where they actually wanted to see the disruption in mental health services caused by COVID. And they found out that about close to 90% of these 130 had a major visible disruption, and about 60 to 70% of the services were not accessible during COVID in these countries. And many of the countries, about 80% of the high income, 50% of the low income countries, implemented as part of the COVID response plan some issues to tackle the mental health problems. But many of these countries, about 80%, did not receive additional funding for this. Mm-hmm. So here we come to another problem. One thing is get your results out and noticed, get in discussion with the right people who are able to change something. And then comes to it, it's very nice to have a plan, but usually these plans require funding and where this funding comes from. Mm-hmm. So I think these are 3 layers of potential challenges to overcome.
Yeah, and when it comes to the funding and mental health related funding in Austria, would you be willing to compare the country with others? Are we in the lead here, or are we in average or below average?
I think if I compare to many countries, we are not in a bad place. Mm-hmm. Yeah. If I compare, for example, the availability of psychotherapy or psychoanalysis in Austria with the United Kingdom, where I'm also very aware of the situation, we are much better off. Yeah, mm-hmm. to provide available treatment mm-hmm. for the people. So I think in international comparison, we are not so bad, but this doesn't mean that COVID is not impacting our people and our population in Austria. And we found out again in the same study, and I don't want to read too much into these results, but for example, the people who had previous mental health treatment prior to COVID, only 30% of these actually had mental health service use during the COVID time. I'm talking now about the first lockdown, so the initial kind of first few weeks. This potentially means up to 7% reduction in mental health service access. I'm not saying that this is the true number. Many of these people didn't need mental health services, but definitely this is an indication of very similar findings like the WHO.
Yeah, and that's also very interesting from another point of view, which is if you have these figures and if you have the Austrian legal political system, who would be then the group or the person changing this? I think it's very difficult in your layer system to target the target on layer 2 and 3, because it's not just the health minister, or it's not just the social security system or region A or B or the individual doctor treating the patient. It's such a complex mixture of institutions, people, responsibilities. Is there anything important happening in the reorganization of this from your point of view that should be highlighted or emphasized?
Yeah, I mean, in mental health, and I think this might be very interesting for your department and area, actually a lot of telemedicine and e-health interventions have been implemented, not just in Austria, internationally. And this is definitely better than not being able to have access to services. And I think the speed of expanding this type of care has been never experienced before. And I think in terms of data security and legal issues, this would have never happened if we wouldn't have had COVID. This has positive impacts. It might be more flexible. It definitely provides a short-term solution while we have the pandemic ongoing. Some treatment options, we have evidence that they work, for example, cognitive behavior therapy. This can work just as well online as in person. So I think if I have to say something as positive, this is a positive impact. But, and here comes the but, will this be kept up, and to what extent? There is still among clinicians debate whether this should be seen as a positive change, and some of it kept after the post-COVID, during the post-COVID area, or we should return to traditional mental health care as we had prior to COVID. I think the real reality will be somewhere in between these two opinions, but I think it will be fascinating to see what remains there from the digital new interventions and provision.
Yeah. I may say that, of course, from my discipline, this is a dream, because there are so many wonderful legal questions in this, and so many interesting issues, from data protection to data security
exactly.
to property questions, etc. Very interesting. But let me just emphasize one question here. I would assume that accessibility to e-health solutions in mental well-being has a clear social implication, which is that only people who have the necessary income, who have the necessary education, etc., have the room where they can have an online session, etc., are able to make use of this, whereas people who are much more under pressure may not. So I would assume that this might be one more brick in the wall of social separation in this country.
Yeah, the inequalities will grow. Yeah. I mean, we see this not just with mental health, we see this with children, you know, but I don't want, this is a huge topic, and I'm sure someone else will talk about this in this series, or already have talked about this. Yes, you are absolutely right. But then here comes again, I think a lot that is happening in a healthcare system is actually influenced by how things are reimbursed, how things are funded. And this is a crucial point. So sometimes I have to move away from mental health for a second to explain what I mean. For example, there are simple operations that maybe someone is able to do as a day surgery. Someone goes, stays for a few hours, the surgery is done, and then in the afternoon could go home. But if the reimbursement system works in a way that the hospital would only get this cost refunded if the patient is hospitalized for a night to stay in the hospital, then of course there is an incentive, a tremendous financial incentive, to treat these patients as inpatient and keep them for a night. Again, I think tremendous legal, social, ethical issues here. And I think so when you said who should make these decisions and who should be involved and what will happen, I think this cannot be a single decision of social insurances, a single decision of ministries, a single decision of academics, or I think we need all of these people around one table to discuss and try to preempt the consequences of these funding decisions.
And again, the question is how to organize the forum in which this debate should then happen, because
when I arrived to Austria, as again I said, in the UK, this works very differently, and I had a different professional experience. There were some attempts for one of our projects where I hope to bring the different stakeholders around one table and have a joint project funded with all stakeholders involved and have transparency. I failed to establish this so far. I haven't given up the aim. This is again, I think you have to overcome here structural boundaries that is embedded in a long historical background, and simple, the society needs time. But again, as much as COVID is a tremendous negative impact on all sides of our life, this might be, again, I would like to see that I see here positive developments when I compare to 7 years ago, definitely in terms of interest in evidence, discussion about evidence. And I hope that the picture you painted, where we can be involved more also in the solution side and not just the diagnosis side, then that this will come as well.
Yeah, I hope so too. And I think this is one of the, in all the many of these conversations, one of the topics that always pop up, which is we need to work on the transformation of the evidence, or of the empirical, or of the the academics research outcomes into the political system in a more efficient way than we did so far. And I think this is one of the things that will certainly remain after this crisis, if it should ever be over. But it will again be very interesting to see then how this incentive system bringing people to voluntarily contribute to this will work, because as you probably share with me as an impression, it's not really the first thing an academic is paid for, right? It's not. And it's not really the first thing our careers are built on.
Yes, although again, I mean, if I compare to the UK, there now your academic work value is based not just on impact factor of publications, but on impact. And impact, how it's defined, is something completely different. And impact would mean contributing to new clinical guidelines, contributing to new reimbursement systems, contributing to new pricing arrangements, etc. in my field. Obviously, this would be something. And hopefully this will come.
Yeah, and at the same time, I'm not too familiar with your field, but I would assume if there's a vacancy somewhere and somebody is appearing with 3 high impact journal articles and the other person is coming with important debates with local politicians on the COVID-19 crisis, it's not necessarily the latter one who will get the job, right?
Yeah, but I think I'm not saying that you should have interesting discussions with politicians. That's already very far from evidence I'm talking about. I think you have to have the capability or the ability to develop solid, robust, objective evidence, which is not there to support certain interests.
Yes.
And then you have to have the ability to translate this evidence and discuss this and influence with this evidence the ongoing decision-making debates. I'm not saying that position should be done where you have nice discussions without anything in the background. That's far from the point. But another point that I think maybe is also important here, if you read this morning the newspapers in Austria, there is now this discussion going on about the AstraZeneca vaccine. I don't know whether you have seen that. Some information was spread about that it doesn't work for age groups 55, 65 over. And it turns out that this is shown in the media as, you know, if I am a layperson, I read this, it doesn't work over 55, 65, I don't want to get the AstraZeneca vaccine. It's already influencing the public's mind. What turns out is the truth to be is that simply the clinical trials which AstraZeneca conducted had very few people in it, participants, who were over this age group. So it's not that it doesn't work, we simply have no evidence of effectiveness. And it's a very different thing from no evidence of effectiveness from evidence of no effectiveness.
Of course.
But until this is not shown to the public, this kind of information can be completely misinterpreted. And I think where I also see our role very important, experts in whatever field we are, legal aspects or health economics, to make sure that evidence is correctly provided to also to the greater public.
Yes. So this brings me back to the possibility to clarify again what I wanted to say before. Of course, by no means I wanted to make fun of your discipline by saying, let's speak to somebody and try to influence those people. I just wanted to emphasize that perhaps the way how academics are incentivized in your discipline and in my discipline might not necessarily correspond with a system where such an expertise like the one that you are mentioning at the moment is urgently needed. Because if you give an interview today explaining that the vaccine is not effective over 65, but it's just not clear whether it's effective or not because the testing group was too small. This is time that you need to invest into communication to the public with your personal and academic background that you cannot invest in writing a high reputation paper.
Exactly. Yeah. I think we are on the same page. What I'm saying is that it's how your output as an academic is evaluated needs to change.
Yes.
And this is again a paradigm shift. This has already happened in the UK. There, it's not just the impact factor that is taken into consideration. Currently here in Austria and in many other countries, it's still the old style, let's say, in this way. And obviously this is another hindrance towards that ideal we are talking here, where academics and experts, not necessarily academics only, are involved and can be involved in more decision-making debates. But to this, again, maybe another point, which I think is generally very important, is going back. You need robust, solid evidence. This requires time, this requires methodological knowledge, and this requires funding. Funding which makes sure that you can conduct relevant studies. My field, or public health in general, was nowhere on the agenda. We are spending from our healthcare budget less than 2% on public health. And this is the same with research funding. I don't know how is it in your field or whether this is of any concern, but until you are a basic scientist in medical field, you have fairly good access to sources of funding. Until you are a more applied health services, public health researcher, it's almost impossible to secure local national funding.
And that's also true for European funds? Or
no, not at all, not at all. And that's why it's not accidental that a lot of the work we do is via European funding.
Yeah, that's the same is true for my discipline. It's when the more application near it's getting, the more it's European money, right? So yeah. And an additional question to this, perhaps, would it be a good outcome then to receive more project related basic funding from Austrian sources, or would it be necessary to change the whole system in the sense that non-project related basic work is also possible? Because that's one of the problems that I see in my field, right? It's always from project to project to project to project, and the overall performance of the discipline as a whole might get into trouble because of this, 3-year, 4-year, 5-year cycles in which you are in.
I mean, you need projects, whether we are talking about competitive grant-funded project or someone gets some money to do quick research on something. I think it would be better if priority research questions again would be decided together with involving the decision makers and what the system needs. And if there would be then proper funding behind this, but this would be done on a competitive basis and not in terms of who knows who or where a quick funding can be done for some small questions with questionable methodology, etc.
Yeah. Okay, so there's another room that we could enter about how research in this country is funded, which is very interesting, but probably a little bit far away from the COVID-related issues of this talk and the mental health-related issues. Let me perhaps close this very slowly by asking you one more general question, if I may, about the other paper that we did not really stress too much now about this spotlight on the Austrian situation. I found it very interesting that I found a figure there about compliance with the measures taken. And the outcome there was that the compliance was quite okay in the first phase. And I mean, that's now my layperson's translation of the figure. The question I would have now is whether you think that has changed and whether there is a relationship between the mental well-being part of your research and the compliance question. So are people with poor well-being less likely or more likely to comply with the rules?
Yeah. So overall, about 3/4 of the people reported that they were happy in the first lockdown with complying the measures. This went down during the second lockdown. We again asked about the public health measures and how what is the perception of them and how they comply with it. So you are absolutely right, this went down. But again, for example, if you look at mask wearing, during the first lockdown, people found this less necessary than during the second lockdown. So this is again changing shifts. What was the most, I think the two key public health measures I would like to mention in this respect. One is contact to family members and close relatives and friends. This is the one that people complied with least. And this remains this finding, and they find the most critical. And here I again go back. It would be something that could be possibly very sensitively treated in future lockdowns. We see that in the current lockdown, there are some improvements already. Yeah, for example, you can visit people in elderly homes, etc., although restricted, but some relaxation was here. And this could tremendously improve mental health, well-being as well. This is one of the measures that was very much impacting anxiety and isolation, feeling of isolation, and generally a development of mental health conditions.
Okay, so that's certainly a lesson to learn. I'm very grateful for this. Professor Simon, thank you so much. Is there anything you want to add? Any last important point before we close this session that you want to share with us, or did we cover all the necessary points already?
No, I think we covered everything. I think there is just one point maybe I would like to come back at the end, that while COVID is very much an infectious disease with severe consequences, hospitalization and death, there are other consequences of this, and we should not shift the focus in our healthcare system only to one illness, and we have to make sure that people who already had previous health issues, people who will have health issues, physical or mental health, as a consequence of COVID longer term, and also people who work in the system and are the key to run a healthcare system, their health is also taken care of, and it's not forgotten in this extremely difficult situation.
Thank you. Indeed, I completely agree with you. Thank you so much. Thank you for this 1 hour. Thank you to our audience. Please stay with us, stay informed, and stay or become healthy as quickly as possible. All the best to all of you. Have a good afternoon. Bye-bye.
Thank you very much for having me.